Hello, everyone. My name is Sethi. I'm one of the first-year cardiology fellows at the University of Kansas Medical Center. I have an interesting case here. All right, I don't have any disclosures. The patient was a 58-year-old male who presented to the ER after he had an ICD discharge while he was driving. He didn't have any other symptoms other than his baseline, where he does have some ongoing orthopnea. Otherwise, he was at his baseline for hemodynamics. Device was interrogated. It was in the VT-VF zone. Ventricular rates were 273, and that's when the device, initially while it was charging, gave an 8-beat burst of ATP, did not convert back, and then eventually discharged it defibrillated. And we did get a surface ECG, which did show after conversion that he was an AFib, which was his baseline rhythm. So these are the EGMs and ECGs from the event. Let me see if I can. This is through the episode while it's going on. This is where the ATP was, and this is where he was cardioverted. And this is the surface ECG, atrial fibrillation, close to normal rate, with some PVCs. His pertinent past medical history of non-ischemic cardiomyopathy with recovered EF. EF was as low as 30%, recovered to 60% as recent as in December. Had a single chamber ICD, had history of severe functional MR, ROA of 0.4, LVIDD 5.9, severe TR. He did have 2 ventricular leads. One was abandoned in the past. Severe biatrial enlargement, and persistent permanent atrial fibrillation. In addition, he did have CKD stage 3, concentric GN on chronic prednisone, hypertension, hyperlipidemia, hypothyroidism. Has tried multiple antiarrhythmics in the past, and currently just being rate controlled. So when he got admitted, there were a lot of acute comorbidities which were thought to be the trigger of his presenting symptom. He was diagnosed with a community-acquired pneumonia, which was superimposed on a recent diagnosis of influenza B. He was also immunocompromised. Cultures did grow Pseudomonas and E. coli from different sources, so didn't really know the significance of that. He was appropriately treated. He did have acute kidney injury on presentation. His creatinine was as high as 4.1, baselines around 3.5. He had supratherapeutic INR of 6.2. So regarding his atrial fibrillation, we were basically rate controlling him with metoprolol, and his rate stayed in 140s. This is despite his resolution of his pneumonia, acute infection, no other acute illness going on. And that's when electrophysiology, they planned on doing an AV nodal ablation, also considering his past medical history where he has failed multiple antiarrhythmics. So this is day 8 since admission. After he has completed a course of antibiotics, his repeat blood cultures have been negative. Now, he does undergo a successful AV nodal ablation. Not a lot of sedation used, 2 milligrams of midazolam, 100 micrograms of fentanyl. That was throughout the procedure. Immediately post-procedure, while in recovery, he had acute hypertension. His blood pressures were as low as 50s for systolic and diastolic 30s. This is while he's being paced at a rate of 90. Bedside EP echo did not really show any pericardial effusion or any change in the EF. This was very limited, so we did not have anything more than that at that time. He was stabilized with use of some crystalloids, phenylephrine, and norepi boluses, and subsequently started on dopamine, norepi, epinephrine, and epinephrine seemed to stabilize him the most, and as soon as he was stable, he was transferred to the CICU. Now, the first day in the CICU in the evening, we were surprisingly, we were able to wean off pretty much everything. His pacer rate was decreased to 80 just because we thought he was hemodynamically stable. Initial impression was it vasoplegia with just the recent sedation use versus was it really an infection? He did get a central line placed with all the inotropes and pressors. His CVP was low, so we did challenge him with some fluids. Having said that, soon he was unstable again, pressures as low as 50s over 30s. Again, within 5 to 10 minutes, it improved again with the use of inotropes. Now, overnight, he was stable hemodynamically, but he did have acute hypoxia, chest X-ray was suggestive of flash pulmonary edema, diuresed well. In the morning, next day, this is just a chest X-ray with some pulmonary edema. Now, he kept having such similar episodes, and those episodes lasted anywhere from 5 minutes to an hour, and then he would be able to be weaned off. Now, we did, during one of those episodes, we were able to capture a bedside echocardiogram, which did show worsening mitral regurg with flail of the posterior leaflet, and that was dynamic in nature. While he was stable, he did not have that. So eventually, given his ongoing condition, we did consult the valve team. He apparently was being evaluated for a mitral clip as an outpatient as well prior to this current presentation, and he was deemed not a surgical candidate. For further management, we did get a left and a right heart catheterization done in the lab, and there was no obstructive disease, and that was pertinent. We were also looking for giving the new flail leaflet and making sure there was no ischemic component to it. He hadn't had any ischemic workup in about 8 years. His right heart catheterization showed RA mean 6, RV 43 for systolic EDP 6. PA 40 over 15 with mean of 23. Wedge was 15 with V waves 28. Again, he's in AFib, so it's not the most reliable readings. His index was, output by thermodilution was 3.6, but by indirect FIC was 8.9. This, again, is in the setting where he does have severe tricuspid regurg, as well as something happened while they were checking the thermodilution. And I'll talk to you about that in the next slide. So as they were checking the thermos, they noted a significant waveform change, and he had a spike in his V wave, and V wave pressures were as high as 60 millimeters of mercury. And at that point in time, he had an intra-aortic balloon pump placed and transferred back to the CICU. This is a TE image as he was being worked up for a mitral clip. This is a still image, does not do justice to his severe MR. If you see, the posterior leaflet appears to be near flail. There are 2 separate jets. There was pulmonary vein reversal as well. This is the initial wedge. This is the wedge when the V waves were as high as 60. Now, this is now next morning. And again, one moment he's stable, and then the next moment he's not. And within that episode, we were able to check his mixed venous, calculate his indirect FIC. His index was as low as 1.4. At the same time, his lactic was 6.2, and mixed venous was 39%. This is while he's on all of these dobutamine, epinephrine, vasopressin. He was augmenting well with his balloon pump at 1:1. Of note, with his hemodynamics, we did his SVR was on the lower side, close to 600 to 700, and he was never stable enough to use any other vasodilator to help with his mitral regurg. So eventually, he underwent mitral clip implantation. He got 2 mitral clips with minimal mitral regurg. The lateral mitral opening gradient was 3.3 and the medial was 3.5. He stayed hemodynamically stable with normalization of his cardiac output, cardiac indices, lactic acid. Now, these are still images again from post mitral clip implantation. Now, talking about potential points, what really led to this presentation. This all started after the AV nodal ablation. On review of literature, I came across a study published in American Heart Journal in 1999, where they prospectively studied 13 patients comparing pre-AV nodal ablation echoes, CAT numbers, and post, and they clearly established that there's AV nodal ablation can, along with RV pacing, can lead to worsening of mitral regurgitation. So is that what really happened? Our suspicion is probably yes. And regarding managing this patient, what else could have been done? There have been case reports about where worsening MR has been just treated with biventricular pacing instead of just RV pacing. Having said that, given the acuity of our patient, and pretty much with the index of 1.4, we thought mitral clip probably would have been a better option moving forwards for him. Other points to talk about what to do when his index was 1.4. We did speak with the whole shock team. They were indirectly already involved with the surgeons, with the interventional team, and the advanced heart failure cardiologist. Patient already is on multiple inotropes, vasoppressors, and the balloon pump. Do we escalate to any further? With his all other comorbidities, he was definitely not a candidate. He did not really have an exit strategy in terms of a VAD versus or a transplant. So the only realistic option we were left with was a mitral clip. We'll be open to suggestions what else we could have done.
Great presentation. Before others are thinking of questions, I'm sure there will be a lot of questions. Could be a more simplistic, I'm going to come to Ramesh, a simplistic approach that this patient was on prednisone 5 milligrams for a long time, went through a severe hemodynamic and septic challenge. Could this be an acute adrenal crisis? And then to treat that, the patient needed more and more vasopressors, and as it needed more and more vasopressors, the afterload increased, and the MR got worse. On top of that, now you did AV node ablation and got dysynchrony, and that MR even tripled, and that's how it got worse.
So in this situation, I had to skip a few things just to compress this presentation. So patient was already on a stress dose steroids. He was on 60 milligrams of prednisone, and that was with the suspicion that maybe he has Sjogren's disease, as rheumatology was following him and suspecting type 3 cryoglobulinemia.
Ramesh.
So, and then we did switch him to hydrocortisone, not that of the equivalent dose. Probably did not make any difference to that.
So several issues. The abandoned leads and you had bacteremia. Was consideration for TEE done at that stage to make sure he doesn't have endocarditis?
So not at the initial stage. His bacteremia, again, going back, he had different organisms, different sources. We are not very convinced if he was actually bacteremic. He did get treated. He did have repeat cultures. They were all negative. So he did not have a TE to start with.
Okay.
This was only done when he was being planned for mitral.
So in terms of AFib, even though it was a shock relating to AFib with rapid ventricular response and would have been deemed inappropriate by strict criteria, it's an appropriate shock for a sick patient. For that rapid AFib with rapid ventricular rate, right? So hemodynamically an appropriate shock, even though for the rhythm. If the patient didn't have all the other features that you mentioned, namely severe MR and very dilated atria, but actually, instead of going for an AV node, some of these patients would be a candidate for ablation for AFib, even though in this patient, that would have been a very moot point and would not be recommended. When you AV node ablate this patient, the clue that the pressure dropped right away. We have taken some of these patients and done a temporary, he's not a candidate for a permanent implant at the time because he's got ongoing bacteremia, but we've done a temporary external LV lead with triggered pacing. Okay. So you essentially BiV pace right away. Don't wait until he deteriorates because that's a very predictable course. And whether he had a flail leaflet or what, when you have severe MR to begin with, your ER, 0.4 regurgitant orifice, when you take a patient like that and AV node ablate him, it's not a surprise at all that they're going to deteriorate. In fact, and then plus you have a very low stroke volume, and if you try pacing him faster, you're going to have more progressive hypotension and deterioration. So we've actually taken patients with an externalized LV lead and just set it up for triggered pacing. So you can either just pace them LV alone or BiV with triggered pacing, so you can get BiV pacing until he's bacteremia is cleared and he's at a point where he needs, and then you can make a decision as to whether you precipitated the need for a mitral clip. He may have needed a mitral clip anyway, but I think doing the asynchronous RV pacing just sort of precipitated the need for that as well.
Good point.
Yeah, so a couple comments on the structural side of this. I think it's a great observation. In the COAP trial, as we randomized patients, half of the patients went through a series that included BiV pacing, and in that group, as I say, half patients who were entered severe MR, depressed LV function, ended up actually improving to the point where the MR improved and they did not undergo the procedure. That was one of the reasons it took 5.5 years to get that trial done. Secondly, about 20% of mitral valve competence is related to atrial contraction, and so when you take that away, it's not surprising that you may have then worsened the MR as well. So good to be thinking about that, and I think it's an interesting observation to have made.
Great. Dr. Nathan?
Can the panel comment on the cardiac index index being 1.4 and considering mitral clip, when clearly we have some controversies in our own center. We look at the PA catheter numbers, we look at the RA numbers and LA numbers, which is the wedge, and also the cardiac index. In our personal data, if the cardiac index is less than 1.5, they really don't do that well because you're compromising the stroke volume further.
So I think if that was a real number in terms of myocardial function, that's correct. I think in this case, obviously when you did assumed FIC with saturations, that probably was contaminated by the backflow from the tricuspid regurgitation. The other point I would make in that same situation is we would consider potentially, and I don't have enough information to comment on that, but there are many patients who have tricuspid regurgitation, particularly in the setting of these leaflets that are pushed aside by the pacemaker, that you can actually turn and do a clip, or now 2 or 3, as you come out, and improve the tricuspid regurgitation, which often improves patients as well.
So just as a point to add on, so he's about 5 weeks out of the procedure now. I had a repeat echocardiogram. His tricuspid regurg is already better. There was a comment made when the T was done that one of the leads was really pushing the atrial, interatrial leaflet really against the wall, and can that be revised? And that was thought about as well. It was just the chronicity of the lead and him being acutely sick. The lead wasn't extracted. So there was a lot going on with this patient, and I just had to compress.
Incredibly ill. One of the interesting points is when you clip somebody, they don't care how many clips you use and how many valves you clip. It all becomes the same charge. So there's some impetus to try to do it all at the same time.
Yes. Thank you very much.